Right, hello everyone. Welcome to our ophthalmology webinar with Mr Damian Lake, one of our consultant ophthalmic surgeons here at the McIndoe Centre. I'm Josephine Trotter, Head of Marketing and Sales, and I'm delighted you've joined us as we explore one of the most common yet transformative areas of eye surgery, cataract treatment and refractive lens exchange. Mr Lake brings extensive experience in both NHS and private practice, with a particular focus on advanced cataract techniques and lens-based vision correction. Before I hand over to Mr Lake, just a quick reminder that this is a live event and the recording will be emailed to you tomorrow. We're not able to respond to raised hands, so please pop any questions into the Q&A box and we'll answer them in the end. If you'd like to stay anonymous, just tick the box when submitting your question. And with that, I'm very pleased to hand over to Mr. Lake.
Thank you very much, Josephine. Thumbs up if you can hear me. Yes, perfect. So I'll be discussing cataracts and refractive lens exchange this evening. I perform this at the McIndoe Centre in East Grinstead. A little bit about me. I've been a consultant. I was a consultant in Queen Victoria Hospital in East Grinstead since 2008, and there I ran the cornea transplant unit and also did the advanced cataract surgeries. I'm a specialist in cataract and refractive surgery, but also do glaucoma surgery and refractive surgery. I'm a former board member of the UK and Ireland Society of Cataract and Refractive Surgeons, and also a member of the European Society, the Royal College of Ophthalmologists, the American Academy of Ophthalmologists, and I'm a published researcher with over 30 published peer-reviewed papers. To begin, we'll discuss just in general the anatomy of the eye. So when we're talking about the eye, hopefully we've got two of them, but not always. And the eye anatomy begins with the eyelids, of course, which protect the surface. And below that is the cornea, which my cursor shows here, which is the clear front window of the eye. There's a front chamber called the anterior chamber. And then the iris, which is the coloured muscle inside the eye, which opens and closes the pupil, which is a hole in the iris. Behind this is a natural lens, which is quite mobile when we're young, under the age of 40, but over time becomes hardened and there's an inability for that to change shape. And therefore, usually around middle age, we begin to lose our near vision and start requiring reading glasses. So the eye is a bit like an old-fashioned camera in that it's got a lens at the front, the cornea, the natural lens, which in youth is dynamic and gives us a range of focus. And those two together focus the image at the back of the eye on the retina, which is like a film in an old-fashioned camera, and then the picture goes down the optic nerve, which is a big visual nerve at the back of the eye, and then off to the brain for perception. So we'll talk a little bit about those throughout the presentation. If it lets me move on. So if you come to the McIndoe for a consultation, the consultation will involve initial vision testing, which you'll be familiar with at the optician, where you read letters on a chart. Then there'll be imaging performed by our technicians, and we've a wide range of diagnostic equipment, which has been invested in by the McIndoe and Horder Centre to provide cutting-edge 21st century images of the eye, which enable us to give you an informed decision about how you want to proceed with any surgery and about the health of your eye. After the imaging has been performed, then you would have a consultation with me, the consultant, where I'm finding out about your visual needs, what your visual history is and your general medical history. I'll find out about your activities, what you like to do, whether you're a driver, the sports or hobbies that you engage in, because that helps me to then give you advice on what best style of lens or what best style of surgery might suit you, or if any at all would suit you. After we've had that discussion, then we then move on to the consultant examination, where I will examine the eye. And when I'm examining the eye, I'm looking for the health of the eye, but also if there's any exclusions from the surgery. Following that examination, I've then got all the information that I require to have a discussion with you. I can then feed back to you what I've found, what the diagnostics have told us. You will have told me about your visual needs and what you want to achieve, and then I can give you a realistic idea of what can be achieved from the surgery. And at that point, you can either make decisions if you've got strong opinions at that point, or there'll be information to take away so you can consider that with your friends and family, gain other opinions and decide how you want to proceed from there. So when the consultant examines the eye, this is a view that they see through the slit lamp by a microscope, which is that instrument that you put your chin on and there's a light that shines across the eye. We're looking at the front window of the eye, the cornea, to make sure it's nice and clear, that there are no scars, no dry spots on the surface of the eye, which can affect your visual quality. We're looking at the eyelids to make sure that they're perfect and that there's no issue with the spread of the tear film. And just behind this pupil is where the natural lens is. So we're looking to see whether that's clear or not. If it's clear, then of course that's healthy. And if it's cloudy, then we would call that cataract. So when the natural lens becomes cloudy, it looks like this. There are various types of cataract. This would be called a sutural cataract. You can see these white opacities within the natural lens, which will be causing visual deficit. They may cause glare or blurred vision. Other types of cataract you can see here. So we can just about see the cornea here, but then there's the depth of the front chamber of the eye. And then beyond that, in the pupil plane, you can see this sort of yellowy, greeny sort of color. And that's when the natural lens has gone yellow, and we then call that cataract. This is a type of cataract called a nuclear sclerotic cataract, where the central lens becomes more and more dense. Commonly, the symptoms of this initially may be that you become more and more short-sighted, but then at a certain tipping point, the vision may become so blurred that you are unable to see at any distances. At that point, you may become symptomatic and attend your optician, who will diagnose you with cataract at that point. So after you have seen it, or you've had your vision measured in the clinic, you then have some measurements taken. It's important that when you come to the consultation that you've not worn contact lenses for some time. Sorry, there's a dog barking in the background. I'm going to shut the window. That you've not worn any contact lenses when you come to the consultation. And we use a very accurate laser system to measure the eye. You can see in the center of the screen here, it's aligned with your pupil. And then the laser will measure the front depth of the eye. You can see the natural lens here and the pupil margin. And all of this is happening in real time. We then measure the full length of the eye. And because it's all done by laser, the combined time of the measurements is under 45 seconds, in which we get an accurate measurement of the length of the eye and the curvature of the eye. And it's with these very accurate laser measurements that we're able to work out what lens power is used inside the eye at the time of any prospective surgery. We also measure the surface of the eye, because when we calculate the style of lens that's going to go inside the eye, the two important measurements that we use are the curvature of the front window of the eye, called the cornea, and also the length of the eye, called the axial length. Now, this map here is like an ordnance survey map of the surface of the eye. And you can see that there's a scale on the left-hand side, and the very steep areas are in red, and the flatter areas are in greens and yellows. So this top left-hand map here demonstrates to me that it's very steep in this direction at the 90 degrees, and it's very flat at the 180 degrees. And that would be indicative of a condition called astigmatism, which you may have heard when you go to the optician. And astigmatism purely means that instead of having an equal curvature to the cornea, so a bit like the side of a football, In astigmatism, it's much steeper in one direction than the other, a bit like the side of a rugby ball. Now, the clinical significance of that is if you do not correct astigmatism, then you will need glasses at all distances, and your vision will not be quite as good as if you corrected the astigmatism, which we'll come to ways that we do that later on in the presentation. It's important, of course, that the film at the back of the eye, the retina, is very healthy. And to be assured of that, we do two things. First of all, we put eye drops on the eye to make the pupil big, so we can examine the back of the eye directly to make sure it all looks healthy. And we also perform an advanced imaging test of the center of the retina called the macula to make sure that that's very healthy. Now, the macula is in this photograph here, and the center of the macula is called the fovea. You can see different layers of the macula here. So underneath the macula are blood vessels which support the cells of the macula, because the macula is obviously picking up light all day, every day. So there's a lot of metabolic activity, so it needs a lot of energy and a lot of oxygen, so it needs a very dense blood supply. So we check that the blood supply underneath the retina is healthy. There's a pigmented layer, this white layer in the scan called the retinal pigment epithelium, which is actually dark in color in real life, and it prevents light which enters the retina from bouncing out and hitting the photoreceptors again and causing optical confusion. So just above the retinal pigment epithelium, this black band here is filled with photoreceptors which pick up light. And those photoreceptors are either rods, which pick up low levels of light, so in twilight, or cones, which pick up light in bright light and see color. Now, the center of the fovea has got the highest density of cones, and this is where you have your fine visual acuity, so your ability to see fine detail. So it's important that we image this and make sure it's as healthy as possible, because if this isn't healthy, then there is no style of lens or no style of surgery which is going to improve the vision if we don't make sure that the macula is healthy in the first place. So it's important to achieve the best outcomes, that that's imaged first to exclude any other issue. You can see here, this is a direct photograph of the macula and fovea. This patient has got a nice healthy optic disc here and nice healthy blood vessels, but you can see all these white dots within the central macula. These white dots are called drusen, which are collections of abnormal material in the retina, and this would be indicative of something called age-related macular degeneration, which is probably the commonest cause of visual loss as people get older. Now, in this circumstance, there would be certain exclusions from cataract surgery. So cataract surgery could still be performed, but the range of lenses available may be less. So having done the imaging, we can talk about the risks and benefits, and we would be able to talk about the styles of lenses which were available to this patient. But the point is that when you come and have the examination, you need dilation drops to be able to see the back of the eye, and therefore, hence afterwards, your vision will be blurred for a few hours afterwards. So when you come to the examination, you'll need someone to drive you home, because it won't be suitable that you drive home after the examination. So after the examination has happened, or after the diagnostics have been performed, we then look at a medical history to find out if there's anything significant that's going to direct the surgery. So for instance, diabetes or blood pressure problems. We look at the eye history. Have you had eye surgery in the past? Have you had squint surgery? Have you had laser vision correction when you were younger? We then look at your visual needs. So what do you still work? Are you retired? What hobbies? Anything else that you might expect that might be unusual? We look at your personality type, because often that can affect the different styles of lenses which may be suitable for you, whether you're a very fastidious person or an easygoing person. We look at whether you drive at night and during the day, and how dependent you are upon driving, because there are certain lenses which may give some glare and halos at night, particularly multifocal lenses, which you therefore may not be suitable for if you do a lot of nighttime driving. Now, the procedure itself is performed under local anaesthetic. So this is eye drops to numb the eye, and you would be lying down. Now, we clean the skin, and there's a cover over the lashes and a clip to prevent you blinking during the surgery. When you're asked simply just to stare straight ahead at a bright light, and you wouldn't feel anything apart from maybe a little bit of pressure every now and again, which will be pre-warned. The surgery itself takes about 15 minutes on average. Occasionally it can take up to 40 minutes, but the average is about 15 minutes. The first step is to make a very small opening in the peripheral cornea, only 2 millimeters wide. We then go inside the eye and make a circular opening on the front capsule of the natural lens that's holding the cataract. We then use a machine called a phaco machine, which contains a titanium tube which vibrates at 25,000 times a second to create little bubbles which break up the cataract using something called cavitation. The tube has got a hollow bore which then aspirates those bits of cataracts away. It makes a sort of slight noise, but doesn't take very long, less than 5 minutes to do this. Then once the capsule bag that held the cataract is empty and all the strands have been removed, we then inject the new plastic lens inside the little bag inside the eye. The plastic lens comes in a preloaded injector. So it rolls up a bit like a cigarette paper. And then when it's injected into the eye, it unfolds and assumes its natural position and is held inside the eye by 2 arms called haptics. The wounds are then self-sealing, so we don't need to put stitches. And we put antibiotics inside the eye and on the surface of the eye, and then the surgery is all complete. The lenses that we put inside the eye come in various powers, which we've already measured, and we can work out which power to use. But the style of lens will be a discussion between yourself and me. So there are various styles of lenses, either a monofocal lens, which is a very good style of lens. It gives good quality vision in all levels of light, but it's only got one focal length, which means that your vision will be either corrected in the distance or up close, but not both. You can have both eyes corrected for distance and then wear glasses for up close, or both can be corrected for up close and then you wear glasses for distance, or one for distance and one up close, which we call monovision. And there are pros and cons to that depending on what you've been used to in the past. There's a slightly more advanced monofocal lens called enhanced monofocal, which gives you a little bit of extra depth of focus. And then beyond that, there's the extended depth of focus lenses, which will give you a range of vision from about 60 centimeters up close into the distance. And then multifocal lenses, which will give you much more near vision till about 40 centimeters and then off into the distance. And we can talk about all of those. And all of these lenses are available in what's called a toric lens. A toric lens corrects the astigmatism, which we've talked about before. And I'll demonstrate this in the upcoming slides. So the standard monofocal lens, you definitely will need spectacles after, whether it's for up close or in the distance. But it does give good quality vision in all levels of light, so no glare or halos. So it's probably the commonest performed standard implant at the time of cataract surgery, but that's because this one is the only one that would be available on the National Health Service. The enhanced monofocal lens will mean that you're a little less dependent on glasses, so you'll be okay for most things, but you're probably going to need reading glasses for up close. But it gives good quality vision in all levels of light and no glare or halos, because it's of an aspheric design, so a nice even curve. Now, the extended depth of focus lenses are a new style of lens. They give a continuous range of focus from about 60 centimeters all the way into the distance in a continuous manner, which makes you therefore independent of glasses for most things, although you may need glasses for very small print up close. So for instance, we would describe this as being able to give you functional near vision. So if you were in the supermarket and you picked up a packet, you'd be able to read exactly what the packet contained, But if you turned it over and were looking at the smaller print for the ingredients, you would probably struggle for that and require reading glasses for this. But the pros of this lens are that there are no rings on the lens as opposed to a multifocal lens. So the quality of vision in low levels of light is better, but not quite as good as a monofocal. But no glare and halos when you're driving at night. The alternative is something called a multifocal lens, which will make you independent of spectacles for most activities. It will give you near vision at about 40 centimeters, intermediate vision at 80 centimeters, and distance vision. So therefore it's designed for sort of phones and watches, laptops at 80 centimeters, and to be able to see in the distance. But the compromise with that, as you can see on the slide, the lens itself has very faint circles on the lens to achieve that, and therefore the compromise is that when you have that lens implanted, when you look at bright lights, you may see some circling around lights. Now that can particularly affect you if you drive at night a lot, and the quality in low levels of lighting is not quite so good, so you may need to turn the lights up to be able to read in low levels of light. Now all of those lenses come in toric style lenses, which correct the astigmatism, which is that abnormal curvature of the cornea. So you can see in this lens that there are faint marks on the surface of the lens in the far periphery. That's because this lens is powered differently in this direction compared to that direction. So therefore, just prior to surgery, we put a little mark on where the astigmatism is on the surface of the eye, and that enables me then to line up this lens with that astigmatism to correct it during surgery. And if you don't correct astigmatism, it means your vision will not be as good compared to if you have a toric lens and correct that astigmatism. There's not really any increased risk to this lens, apart from the very small chance of about 2% that the lens moves more than 15 degrees after surgery, requiring a second procedure just to dial it back into position. So then we discuss the benefits to you concerning the better vision that you can hope to achieve after cataract surgery or refractive lens exchange. We can talk about the quality of your vision and how that will affect the quality of life that you obtain. And the discussion will be about what you choose. After I've given you the options, you get to choose what you would like, what you would best consider is going to suit you. And it's really a team approach, so we can work out to give you the best outcome. Unfortunately, whenever we do any type of surgery, there are risks, I'm afraid. On the plus side, cataract and refractive lens exchange is the commonest performed surgical procedure. It has got a very good track record. The chances of everything going very well are very high. So 97 out of 100 cases will be straightforward and will settle down straightforwardly. There's a small chance, somewhere between 2 and 3%, that the focus may not be perfect afterwards, in which case you may require second surgery or an additional pair of glasses. But as with all surgery, I'm afraid that they do carry risks. And the worst case scenario in cataract and refractive surgery is visual loss, and the risk of that is about 1 in 1,000 for a standard case. So that's my overview of cataract and refractive lens exchange. I think I'm ready for any questions.
Okay, thank you very much, Mr. Lake, for providing such valuable insights into how these procedures can improve vision and your quality of life. Thank you for those people who have submitted a question already, but if you haven't, feel free to add it to the Q&A box now. In the meantime, we do have some questions. Actually, I've got one that I'm going to ask, which is, when you have cataract surgery, can you treat both eyes at the same time?
That's a very good question and a very topical and pertinent question. So historically, cataract surgeries were usually performed one at a time, separated by very many weeks. And that tended to be the case because it was an operational thing on the health service, in that they couldn't manage to do two quickly, one after the other. In fact, they couldn't keep up with the one, let alone the two. But over time, as technology has developed and the risks of cataract surgery have reduced, particularly after the advent of antibiotics which go inside the eye at the time of cataract surgery, when which has reduced the risk of cataract surgery by a considerable amount. It became more of an option, and it started particularly in the Scandinavian countries. And in the Scandinavian countries, the population don't all live in cities. A lot of them tend to come from out in the countryside, come into the city to have their cataract surgery and then return back home. So more of a sort of a hub and spoke style model of healthcare delivery. And it wasn't really, it didn't really suit them to come backwards and forwards more than once. So it began to develop, particularly in Sweden, to have both eyes operated on the same day. And I began doing that about 10 years ago when I worked with a group of Swedish surgeons in the UK, and they showed me how to keep it as safe as possible and the steps that need to be taken to make sure that safety is key. So when we do the surgery, we use separate equipment for each eye and separate staff for each eye, different batches of the antibiotics and liquids that we use in the cataract surgery. And so I've been doing that for about 10 years. And other surgeons have sort of followed, particularly since COVID, when the NHS had a backlog. They were looking for ways to improve the efficiency of that. And it happens much more on even the health service nowadays. The caveat with that is that it can happen, but it shouldn't always happen. So there are notable exclusions for that. So if there, for some reason there are eyes that have got increased risk factors, then I wouldn't suggest that you have both eyes on the same day. If the patient decides that they don't want it both on the same day, then absolutely that decision must be obeyed. So I wouldn't do it as standard. I would offer it to the people that are suitable for that on the caveat that they understand that there is still a risk of visual loss in cataract surgery, and that risk for one eye is about 1 in 1,000. But if you have both eyes done on the same day, then there is a small risk, which is about 1 in 1,000,000, that both eyes can be affected. So if you decide that it's more convenient for you to have both eyes done on the same day and you accept that risk, then it's fine to do both eyes on the same day. However, if you decide that you're not a person that wants to take that risk, then I completely accept that and would definitely recommend separating them out, one on one day and one on another day. And I don't have any strong opinions about doing that myself. It doesn't make really any difference to me. It's usually for the convenience of the person having the surgery.
Okay, thank you. Right. The next question is, how long does it take?
It's variable. I would say on average, it's probably about 10 to 15 minutes for a cataract surgery. Very rarely it can take longer, up to even 40, 45 minutes. And people might ask me why that would be so. So I usually give the analogy of driving to Maidstone. So most of the time when I drive to Maidstone, it will take me 30 minutes, but sometimes it will take me 2 hours because I come across roadworks or roads that are shut. And it's the same with cataract surgery. Usually this happens, and it takes 15 minutes, but occasionally you can come across unexpected things and traffic lights, and it will take a bit longer.
Okay, thank you. The next question I have, can I be sedated during surgery, as I'm very anxious and can't stand the thought of being awake?
As I said, the commonest way to have cataract surgery is just with eye drops, topical anesthetic, but that doesn't mean that people don't have it with local anesthetic block around the eye. Some people will have sedation. Some people will even have general anesthetic and be put to sleep for their cataract surgery. And all of those are acceptable if you understand the risks and benefits. So I've no strong opinions about that. Anyone who wants topical anesthetic will do that. But if you want something different, then absolutely, it's entirely up to you.
Hey, What happens if I have other eye conditions like glaucoma or macular degeneration?
That is a very interesting question. So we pick up the glaucoma or macular degeneration when you come to the consultation. Either you'll tell us beforehand or we'll discover it in the consultation. And it will affect what we say dependent on a number of things, because all glaucoma is not the same. There are different styles of glaucoma. So in some, such as narrow angle glaucoma, it may be in your favor to have cataract surgery because it's actually a form of treatment for narrow angle closure glaucoma. In those with the more common primary open angle glaucoma, we can combine sometimes the cataract surgery with additional treatments such as stents or tubes, which are small little tubes which go inside the eye to drain the fluid inside the eye to actually help with treatment of the glaucoma. So it's the glaucoma, the diagnosis of glaucoma informs us about other treatments which we might want to combine, but it also can limit the style of lenses that we use for the cataract surgery. But it depends upon how advanced or not your glaucoma is. So if it's very early glaucoma and it's well controlled and treated and there's not very much visual field loss and the visual sensitivity is near normal, then it may not preclude any, you can still have any of the intraocular lenses. However, if you've got more advanced glaucoma with less sensitivity in your visual field, then it may mean that the style of lenses that you are limited to might be either the enhanced monofocal or the extended depth of focus lens. You could still have the toric lens if you've got astigmatism, but it may mean that you may not be suitable for the multifocal lenses, because multifocal lenses make the benefits are great. You get near, intermediate and distance vision, but in low levels of lighting, it's a bit more difficult to read, so you've got to turn the lights up. But people with glaucoma don't have the same sensitivity in low levels of light anyway, so it can make that actually worse. So we wouldn't want to do that. So that may preclude you from having a multifocal lens if you've got more advanced glaucoma. Concerning macular degeneration, again, it depends upon the level of macular degeneration. If it's quite advanced, then it may mean that cataract surgery may not be suitable at all for you. But if it's sort of very early macular degeneration and you still retain good vision, then you may be fine for any of those lenses. But again, in macular degeneration, your sensitivity to light is different. So people with early macular degeneration particularly complain about oncoming headlights. They think that oncoming headlights are too bright, and they say, I get blinded by the oncoming headlights, and they blame LED lights and things like that, when actually it's more than likely their retinal sensitivity is impaired by early macular degeneration. So therefore, they may not be suitable again for multifocal lenses. They may be better off with either extended depth of focus or enhanced monofocal lenses, which will give them a better quality of light, albeit they'll sacrifice their near vision.
Okay, thank you. And then the final question is, if I have good vision with glasses, do I still need surgery?
Well, that is pertinent. So if you have got cataracts, so cloudy lenses, but you've still got good vision with your glasses on, then it's up to you. If it's the health service, National Health Service, then there's probably going to be a limit placed. So if you don't have symptoms, then you're probably not going to get cataract surgery. But if you're obviously paying for your treatment, then it's up to you, because you decide. If you've got cataracts and you prefer to have cataract surgery early rather than later, then absolutely you can have cataract surgery. If your vision is good with glasses and you don't have cataract, then you can still have lens-based surgery. We call that refractive lens exchange, and people may choose to have that done because they don't want to wear glasses anymore. So if you're very short-sighted, or you've got a lot of astigmatism, or you don't see well either in distance or up close without glasses, and you want to get something done about that, and usually you're a certain age, maybe over 50, and your eyes are otherwise healthy, then you may choose to have refractive lens exchange, or which is basically the same as cataract surgery, to correct that visual deficit and to give you better unaided vision and to make you less dependent on glasses in the long term. So the short answer is yes, you can have surgery whenever you want.
Okay, we've actually got one more question has popped up, which is, are all the same lenses available on the NHS versus self-pay?
No. So NHS lenses, usually each NHS trust will have a contract with a particular company to supply usually a monofocal lens. The NICE guidance does not pay for toric lenses or multifocal lenses at this time, or extended depth of focus lenses, although rare trusts may fund toric lenses for a certain level of astigmatism, but in general they're not available. So no, there's a very restricted, you don't get to choose your lens on the NHS basically.
Okay, Damian, I've just refreshed this Q&A and I've got some more for you.
No problem.
So how long is the waiting list for treatment?
If it's privately, then you come to see me, and if you agree that you would like to have surgery, then you discuss with my admin team, and we can book you in usually within 6 weeks, sometimes even sooner than that, depending on the time of year.
Fantastic. Right. Next one. What are the advantages and disadvantages of the new style of spiral lens multifocals such as Galaxy? Do they compromise clarity for less need for glasses?
So the Galaxy lens, which is produced by Rayner, is a type of sort of half multifocal, half extended depth of focus lens. So if you look at the lens itself, as you say, it's got a sort of spiral pattern on it. All lenses, there's a compromise between quality of vision and depth of focus and glare and halos. So the more depth of focus you get, you're likely to get more glare and halos. So Galaxy I would put in the sort of extended depth of focus category. So the glare and halos are in the moderate mild side, but the ability to give you depth of focus is slightly compromised. So there are various ways that you can offset that. So you can decide that both are going to be equal in both eyes, so that you get good distance and intermediate and some functional near, but you need to wear reading glasses for up close, and you accept that you're going to get a little bit of glare. Or you can decide to offset your non-dominant eye, so that your dominant eye will see very well in the distance, and it will give you a range of focus up into about 60 centimeters or so. And then you can offset your non-dominant eye, so it's not quite so good in the distance compared to the other one, but it is better for up close compared to the other one. So therefore, with both eyes open, you get a much greater depth of focus. But the Galaxy has still got the same compromises as all lenses. There can be glare and halos with a Galaxy lens.
Okay. Tim, I've got your question. He's just posted a second time. What is the percentage success rate for all your diagnosis, then surgery, then outcomes that your patients are fully happy with?
So we do an audit each year to look at the satisfaction rate of patients after surgery, and the satisfaction rate was 98%.
Right, that's good. And then the final question, I am going to refresh this though, actually, before I do it, because I've noticed some of them are pulling through a little bit slowly. And yes, it has. It's pulled through some more. So does risk of visual loss in cataract surgery mean blindness?
Absolutely, it does. It's possible that you could be blind after cataract surgery, although, as I say, that is exceedingly rare.
Okay. Can cataracts be too young and supple to be broken up?
In the old days, there was it was taught that the cataract had to be mature or ripe to be able to be removed. And that may have been the case in the 1980s and even in some parts of the country in the 1990s, but it's not the case with modern cataract surgery. With modern cataract surgery, the cataract does not need to be ripe. It can be removed at any level. There would be the same or general risks and benefits. In some ways, it can be simpler to remove the earlier they are. And in some conditions, we may even recommend that the cataract is removed earlier. For instance, if you've got certain corneal conditions, there's a corneal condition called Fuchs corneal endothelial dystrophy, in which the cornea is weak. And we sometimes recommend that the cataract is removed earlier in that condition, because if it's removed earlier, then we don't need to use so much energy to remove it, and it helps preserve the cornea in that particular condition. So no, there's no prohibition in treating the cataract early.
Okay, now I'm going to refresh this just to see whether got any more. Right, so this is the final one. If you have refractive surgery, I presume that you could never get cataracts?
You presume incorrectly. So when we're talking about refractive surgery, I presume we're talking about LASIK and PRK and LASIK and SMILE, which is a type of refractive surgery usually performed on people in their 20s or 30s, in which the cornea is reshaped by a laser. Now, when that happens, it has no effect on the lens inside the eye. So when you get older, the lens inside your eye can still go cloudy and you'll still develop cataract. So therefore, you will still need cataract surgery after refractive surgery in your 20s and 30s. Now, it presents certain challenges to the cataract surgeon later on in life, because if you've had laser vision correction in your 20s or 30s, it alters the shape of the cornea. And there are certain assumptions that we use about the shape of the cornea in calculating the power of the intraocular lens that we then use at the time of cataract surgery. So to make sure that we get the best result, we need to know that you've had laser vision correction so that we can use special formulas to create the most accurate assessment of the intraocular lens power that we'll need to use at the time of cataract surgery. But if you've had laser vision correction in the past, it still means that you will get cataracts when you are older, I'm afraid.
Okay, and we have another one come through. Are there any risks apportioned to those with, for example, Asian or Indian background?
Asian or Indian background. I'm unaware of any additional risk factors for people of Asian or Indian background. Perhaps occasionally, I suppose it's more common in Japan and China that you might have very short or very long eyes, which can increase the risk of in cataract surgery. But Indian Asian per se, I wouldn't apportion any particularly increased risk of cataract surgery just based on that ethnicity.
Okay, that really is it. I'm going to do one more refresh just to make sure. And he says thank you. Right, that's I think that's all the questions we have for today. So thank you again for sharing your experience. Mr. Lake has kindly offered a free consultation for anyone attending this evening. If you want to book an appointment, just use the contact information on screen, and don't forget to use the discount code, which we'll email to you tomorrow with the video of this webinar. You'll also receive a link to a survey with 3 questions for feedback, and we'd love to hear what we're doing well and what we could do better. So please, if you've got some time, we'd be grateful if you could fill that in. There's also a QR code on screen for you to sign up to the newsletter, which is worth doing because it keeps you up to date with up and coming webinars and any offers that we're doing, and it goes out every month. And then I think it just leaves me to say once again, thank you very much for your time, everyone, and enjoy the rest of your evening. And thank you, Mr. Lake.
Thank you very much for attending.
Okay, then. All right. Bye-bye.